Okay. Usual disclosure of relationship slides, nothing to disclose among those involved in this. And our usual grant funding statement, funded by the SOR grant. Again, usual process for CME certificate. If we have anyone new on the day, there'll be just a quick evaluation survey that will be in the chat, as well as we'll come to you in an email later this morning. Just complete a quick survey about today's session, and you will get your certificate. Okay, so we do these in cycles of 4. This is the last in our current cycle of 4. So we'll be off in December to kind of put the next series together, and then we'll be back in January and February with um, 4 new trainings. And we have the topics for these, just lining up the dates and everything. So we've got pregnancy and opioid use disorder, one focused solely on patient cases. We have another person coming in to tell their recovery story. We did that a few months ago. We're going to do another one of those patient-based presentations. And then we've got one on substance use evaluations. As always, consultations are available anytime. Just don't hesitate to reach out to me if there's anything our team can do. And then, as usual, you can register for this next series through today's evaluation. You can just click a box and say, "Yep, sign me up for the next series of trainings." Okay, I'm gonna stop sharing my screen and I'm gonna let our expert panel introduce themselves. Let's see, Ed, would you like to go first?
Yeah, you bet. Hey, good morning, everybody. Ed Kaiser here. I'm a family nurse practitioner in Omaha, Nebraska. Been working with patients with substance use disorder for the last about 7.5 years, primarily opiate use, but alcohol and other substances as well. So excited for you guys to be here. Thanks for having me.
Thanks, Ed. And Mary?
Hi, I'm Mary Ellis. I'm a psychiatric nurse practitioner and attorney, and I work here in Nebraska.
Thank you. Todd?
Good morning, Todd Stoll. I'm in addiction and psychiatry. We are interested in this project. We have, support for funding for this project that come out of some of the federal dollars and so on. And we have another year of providing opportunities for people to get CME. If you have specific topics or things that you are interested in, and I know I've said this before, as has Will, please let us know because we want to make this relevant. We want to make it practical, and we value your input. So if you have some thoughts on given topics or things that you're interested in, please reach out.
Absolutely. Thanks, Todd. John?
Good morning. I'm John Massey, and I'm a pain physician in Lincoln.
Thanks, John. And Alex?
Morning, Alex Dorick. I'm a family physician with a focus on the underserved in Omaha, Nebraska.
All right. Thank you. Stephanie, I'll turn it over to you.
Good morning, everyone. Stephanie Bennington here. I'm a psychiatrist located in Rapid City and Western Nebraska. I'm also seeing patients out in Chadron now, so kind of have a dual area. But let me go ahead and share my screen for you guys. Can you see it?
Yep, I can see your slides there. Perfect.
Okay. So what I'm going to be going through today is a little bit different approach. We kind of focus a lot on the treatment modalities, obviously for substance use disorders and for pain, incorporating a lot of the treatment approaches, particularly pharmacological approaches. Today, I'm going to focus more on the non-pharmacological approaches, specifically psychotherapy, because this is something that we can do with even limited time as patients come into your guys' offices and practice. And, even a few minutes to, a quarter of the visit to half the visit even can make a pretty substantial difference. And by understanding a little bit more of these treatment modalities, then we can hopefully kind of restructure it so that it can be more focused on the individual needs of the patient. And then at the very end, I'm going to touch on a little bit of the like billing codes and ways to be reimbursed for these things that you all are probably doing in your practices, such as like screening tools and the psychotherapy in general, and how that can be incorporated to continue to encourage the use in your guys' practice when you see these type of patients. So I'm going to start just with a little bit of overview in substance use treatment in general, and how we kind of get to the place of where we start recommending treatments and things like that. But historically, anything that that now has kind of a negative connotation, something that we need to change, that we see as kind of bad or punishable, it always kind of has this pendulum swing that we typically see in society. And initially, it always kind of starts out as potentially not bad or potentially even good or advisable, and that's kind of been the take on substance use as it drastically changed throughout many years. And historically, I mean, there's been substances that we've even seen as positive or advisable. I mean, smoking was one of these. And then as the pendulum swings to the other side, we now see it as like a moral failure, as the person's not trying even hard enough. And then we see it as punishable. And that's when typically the criminal system can get involved. And so when that typically happens, where we see it as a moral failure and we see it as potentially punishable, that's when a lot of the research will go into exploring treatment options and figuring out ways to help individuals so that we can avoid the punishment aspect, so we can keep individuals out of the legal system. As much as I love Mary Ellis and the fact that she helps many people in the court system in general, the ultimate goal, especially with substance use disorder, is to keep patients out of the court system. Medical and the judicial systems never really work well together. There's still a lot of ways that we have to go in incorporating those things together, but as of now, there's still kind of a disconnect. So if we can keep patients out of the judicial system, that's the ultimate goal here. And so a lot of our treatment approaches in helping individuals truly with their substance use, and hopefully then can avoid the criminal aspect of it. But some of our treatment approaches that we've had for substance use disorders and treatments spent a lot of time in researching like alcohol detoxification, our psychosocial interventions, contingency management, we'll discuss a little bit today, motivational interviewing, cognitive behavioral therapy, we'll discuss that as well. Our opioid antagonists, we've spent a lot of time discussing these. Irreversible aldehyde dehydrogenase inhibitors, like for alcohol use, or dopamine reuptake inhibitors. I spent some time discussing this, especially in my ADHD and substance use slides. And then, of course, anticonvulsants, methadone maintenance treatment, buprenorphine, antidepressants, antipsychotics, even lithium has been studied as a treatment option. These are things that we've kind of already explored in a lot of our presentations. And so I'm going to explore more of the psychological or psychotherapy approaches here. So when we think about treatment options for a patient, there's kind of a stepwise principles that we kind of take into account, and one is not necessarily more important than the other, but it's like a treatment approach that we have to take all of these principles into consideration when truly helping, truly wanting a patient to go through treatment for substance use and helping them in the best way that we can. And a lot of those have to do with the individual characteristics of the patient itself, because addiction is obviously a complex but treatable condition, and it affects the brain function and, of course, the resulting behaviors of the individual. And so no single treatment will be appropriate for everyone, and that's really taking into account the individual characteristics, whether it be psychosocial factors, whether substance obviously plays a part in it, and the resources available, all of that it takes into account when choosing the right substance use treatment for somebody. The treatment that is chosen must be readily available to the patient. It can't be something that requires the patient to either put in more time or resources that they simply don't have available to them. The most effective treatment is meeting the needs of the individual person, not just their substance use, and then encouraging and finding ways to have the patient remain in the treatment for the longest period of time, and it has to be the adequate period of time. A weak treatment isn't gonna result in significant long-term outcomes. And then the behavioral therapies, which would be the ones that I primarily discuss today. You can look at individual therapies, family therapies, group counseling. All of those are effective forms of treatment, whether it be intensive outpatient programs, or partial hospitalization programs for substance use. All of that would take into account all of those would incorporate those behavioral therapies as well. Medications, of course, are an important part of it. The individual's treatment must be continually assessed with each appointment or each visit that you guys have in the office, or whether it's weekly, whether it's monthly, whatever it is, whatever form of treatment you are doing with these patients needs to be constantly reassessed. Is it the right treatment? Are we meeting the needs of the patient? And is it changing the outcomes? And then, of course, treating any psychiatric conditions, and then at the start of the treatment, whether they need to actually go through medically assisted detox. And just to kind of point this out, to always take into account, this is the first step in treatment itself, but it doesn't change long-term outcomes. So if a patient goes into either the hospital or a program for medically assisted detox, and it is able to come off of the substance successfully, that's not going to lead to long-term outcomes if we don't set them up for the appropriate treatment after they are able to detox from it. Just kind of reminder, treatment does not need to be voluntary to be effective. We have research that shows that even involuntary treatment can be just as effective, such as, even within the judicial system, once we get to that point where they've kind of failed every other option, or those treatment options just weren't available to that patient prior to the judicial system, when it's kind of forced upon them, even that can be voluntary. Again, it must be monitored. The relapses must be monitored during the treatment. And then, of course, as Alex kind of touched on in his presentation, actually taking into account and treating other potentially diseases and targeting that high risk population, and making sure those patients have those resources as well. And this is kind of just a nice overview of all of the principles that must be taken into account when we're treating patients for substance use disorder. And just taking one individual component of this isn't going to necessarily change these long-term outcomes. I mean, we have to kind of take into account the whole patient. And I know you guys know this, but kind of putting into perspective and seeing it in these chart forms, I always find to be very helpful, because these are things maybe we're not always asking, or maybe even kind of it's in the back of our mind, and we're forgetting this can make a substantial difference in somebody's life that may not be something that we're dealing with on a daily basis in our own lives. So it might not be something that we are frequently asking, but some of those psychosocial factors, of course, family services, what's going on at home, our housing, transport services, are they able to get to these appointments? And can we set them up or can we have social work come in and help set these things up so we can make sure patients are getting to the right place so that they can continue undergoing the treatment? Financial services, what are the local services? And then, of course, like for the diseases, like if they have HIV, hepatitis C, things like that, are we giving them the right treatment? Are they able to access it? So I just wanted to put it in a nice little format. Neurotorium kind of does great in having these visual slides available. So the treatments that I'm going to go through today and discussing will be cognitive behavioral therapy, motivational interviewing, contingency management, dialectical behavior therapy, and then I'll briefly kind of discuss the 12-step program, collaborative care. And at the end, I will mention a potential future aspect of treatment, which is actually virtual reality, that it's currently being explored, which is actually pretty cool. I'll kind of touch on that a little bit. And then at the very end, we'll kind of discuss some of the codes too. So a lot of you are probably already doing some of these treatment modalities in your clinic. And I want to make sure that that you guys are able to bill for these, even with screening tools. These are things that can be billable and reimbursable by insurance, and that can encourage continued use of it in your guys' practices. Cognitive behavioral therapy is our most studied, most understood form of psychotherapy, and it's been proven in research to be effective and supportive in a lot of our conditions that we have, including substance use, a lot of our psychiatric conditions as well. And that's because it's a skills-based therapy, and the point of it is targeting the cognitive distortions. So our goal of it is not bringing patients to insights. We're not giving them that insight. We're actually just kind of restructuring the thoughts. And I have another slide on this in the next one that kind of explain this a little bit better. But in substance use, the whole point of it is focusing on the relapse prevention and coping skill development, and giving these tools to these patients will then help preventing these relapse and prevent ongoing substance use. So the studies have shown it's very effective across alcohol, stimulant, and cannabis use disorders especially, but it can be used for any substance use in a lot of our psychiatric conditions as well. So this is a great visual. Again, Nuratorium does a great job in showing those kind of visuals of how it works. And I like it because it kind of shows the point of cognitive behavioral therapy, because we have all these treatment modalities, but sometimes they kind of get intermixed. It's like, okay, well, when would we use cognitive behavioral therapy? When would we use dialectical behavioral therapy? Kind of what's the difference between them? And that's kind of what I want to focus on more today. And understanding, like, because a lot of you are doing a lot of these principles now, and we may not know what we're using, it's working, but my goal is to kind of explain it a little bit more, so then you do know what you're using, so then we have a better understanding of what our outcomes should be. So with cognitive behavioral therapy, it's focusing on a pretty simple underlying principle that these cognitive distortions, they have a controlling influence on a person's emotions and then a result on the person's behavior. So thoughts, emotions, behaviors are interconnected, right? So for example, if we have a negative thought pattern and that initially comes up in a patient's mind, that thought is going to create an emotion. And that emotion is then going to create a behavior. And that behavior, whatever it is then going to recycle back to a thought. The person's going to think different about themselves in some way, whether it's positive, negative. Generally with substance use, it's going to be negative. And so then it reinforces the emotion, the behavior, the thought, emotion, behavior, and it becomes this vicious cycle. And so the purpose of cognitive behavioral therapy is intervening at the thought process by restructuring these thoughts, by changing them from kind of this negative intrusive thought to then restructuring it to something more positive. Then we can create a different emotion in the individual, and therefore that emotion will create a different behavior. So the purpose that we are doing with the cognitive behavioral therapy is just the thought process. And if we can restructure that thought, the emotion will change in the individual themselves, and the behavior will change as a result. So we're not affecting the emotion behavior specifically. We're not doing it directly. We're not changing the emotion or behavior directly. That'll come independent. The only aspect we work on it is just the thoughts and restructuring it to a positive thought rather than those negative intrusive thoughts. And so I'm going to include a case example after each of these and how it can be used, just to kind of put it in perspective. This is a case that I had with an individual with alcohol use disorder. And some of these I included the billing codes as well. But with this individual, he was a 42-year-old male, had never undergone treatment for substance use disorder. He actually came to his primary care office for the major depressive disorder and trying to start treatment for that, which is common, which will be, it's a psychiatric condition, the way they're feeling. Again, that emotion aspect is usually what brings patients to seek treatment. But when he went to his primary care provider, they initiated the screening, normal labs, and it found his elevated liver enzymes, and they had a discussion about that. And then this individual was referred specifically for alcohol use disorder treatment. And he was not interested initially in medications. Eventually, we were able to have that discussion, and he eventually went on Vivitrol later in the treatment option, which was great for him. But the whole first probably about 5 months, we solely worked on just the CBT aspect of focusing on his guilt-driven drinking patterns, essentially. So he would do well for about maybe a couple days, and then something would happen. Either he would get into a fight with his spouse, or he would, maybe yell at his kids because it's hectic in the evening time. Those were the two that he really struggled with the most. He would feel this guilty pattern, and think it's, well, if I was better for my family, if I, it's probably because I drink so much, I should just keep drinking. And so then that thought creates the emotion, which is, I feel bad. I don't like this. I'm bad for my family. And then it results in that behavior pattern. I'm going to go ahead and keep drinking. And so him and I worked on just that thought process, the intrusive thoughts of, my wife deserves better, my kids deserve better. And we worked on changing that to a positive, where when he would think, my wife deserves better, we restructured that to, no, I'm actually a good spouse. These are the things that I've done. These are the parts that my wife actually appreciates about me. I'm actually a good father. These are the things I do great for my kids. And with that, we were able to change his emotion, and therefore he would not go to alcohol as the resulting behavior. So it worked really, really great for him. And at the 1 year mark, he had been without alcohol for about 6 months, and we continued treatment from there solely with CBT and Vivitrol. Motivational interviewing is one that's probably most commonly used in years practice in psychiatry in general. Because it's meeting patients exactly where they're at. You're not necessarily trying to change the behavior, the outcomes yet. You're just trying to get them to the point of accepting that we maybe need to do something different. So you're expressing empathy, developing discrepancy, supporting self-efficacy. You're meeting them exactly where they're at. So this is especially useful in that early recovery and recognizing the substance use. And when patients are on the fence, like, no, maybe I don't think it's a problem. I don't think I necessarily need to change anything. That's where motivational interviewing can make the biggest impact in helping patients get to that point of the stages of change. So is motivational interviewing helpful? And that's kind of always the question, right? Is what I'm doing for that maybe few minutes, is it actually making a difference? And again, Nораtorium does a great job in having these visuals to show the effectiveness of some of these treatments. But yes, it shows that even these few minutes of motivational interviewing, particularly in this case, it was for heavy drinking, shows the outcome, that it is effective, that it does lead to long-term outcome changes, to positive changes of the long-term outcomes. It's a counseling technique in which a person's attitude to changing the behavior are explored. And then hopefully resolved, and then you can kind of transition to the different types of psychotherapy. So with CBT, we were changing the thought to then indirectly change the emotion, the behavior. Here, we are just focusing on changing the person's attitude. So we're not changing their thought pattern. We're not trying to restructure their negative thoughts to positive that we would in CBT therapy. Here, we are just trying to focus on their attitude. Because a lot of times when patients initially come in pre-treatment for substance use disorder, or pre-understanding that they have a substance use disorder, there's kind of a negative connotation. There's a defenses. They're using their basic defenses and saying like, no, I don't have a problem. No, it's fine. Other people do this. It's okay. I could stop if I wanted to. That's the most common statement patients say. I could stop at any time if I want to. These are their primary defenses kind of kicking in, because if they acknowledge that it is a problem, then that creates a negative feeling, and then that creates a behavior and that they particularly don't like. So this is a defense that kind of kicks in, so that so patients don't have to feel that and think those negative thoughts. So by then bringing it up in a positive way to kind of change the person's attitude, then their job outside of seeing you and outside of the treatment is like, well, my provider said this, and they said it kind of in a positive way, so we didn't feel like we had to defend ourselves. So patients will be like, okay, well, maybe it is a problem. Maybe I would be healthier if I got treatment for this. You know, they mentioned a medication at the appointment. Maybe I should try it. Maybe it would be helpful. So a lot of these maybes start going through their minds when we use motivational interviewing. And that's the goal of it, changing it from a no to a maybe and then to a yes. And so then when they come back for subsequent appointments, then a lot of times when you bring it up kind of back in the motivational interviewing phase, then they say, well, you know what? Yeah, maybe you're right. What are my options? And so this study, when it looked at heavy drinking, found that when they looked at the meta-analysis, it found that although the evidence was of some of these were low quality, because it's really difficult to have this in a controlled environment, right? There's a lot of aspects that will that can influence the outcomes of this. It did find that the extent that the motivational interviewing did reduce the extent of the substance abuse compared to no treatment. So, you know, these type of studies, except in a controlled environment, which therapy is not great in these controlled settings for studies, using different sources of these research studies is really all we use, especially meta-analysis when we look at all of them, does find that it's effective, especially in reducing alcohol consumption. And then the last bit I wanted to note was that this study in particular found that age does affect the efficacy of motivational interviewing. But again, more researchers needed to fully understand the interaction. And I've even seen this in my practice when I use this with patients. It really depends on the maturity level, life experiences, which tend to come with age, but this isn't across the board with all patients. I have some patients who are incredibly insightful, even at much younger ages, that even have more insight than older individuals. So it really just kind of depends on the individual characteristics and how much of their defenses are coming into play. So a motivational interviewing case example of a patient that I had was a 32-year-old woman. Again, she had alcohol use disorder, mild depression. Again, she had previously been seen by her primary care provider. That primary care provider did screenings and scored high enough to meet the alcohol use disorder criteria. And that primary care provider used brief motivational interviewing, which I loved reading this note because it was probably one of the best notes of how I saw that the primary care provider actually used motivational interviewing and were able to kind of put the responses down. And so that when she came to me, so that we could work on this, she had already restructured her own attitude of, no, I don't have a problem, to, well, my primary care provider kind of brought it up, and, you know, maybe she was right. Maybe I do need to talk about this. And that's what the referral to psychiatry was. Contingency management is another form of treatment that's successful in changing these outcomes. So kind of recapping, CBT, we're focusing on the thoughts. We're changing the negative to a positive thought pattern. Motivational interviewing, we're changing the attitude of the individual. Contingency management, we are working on behavioral reinforcement. So when we think of that triad step, this is the behavior aspect. So we're seeing something good happen, and then we're finding a way to reinforce that. And then that will change their thoughts, that will change their emotion, and then the resulting behavior. So we're working on that behavior aspect in the contingency management. So how this is most done, I feel like the court system actually does well with this, with a lot of their drug courts. Not all states or counties use this, but the ones that are using it and are using it well are using the contingency management type of treatment modality. And so these are using tangible rewards tied to a desired behavior. So if they come in and they have a negative urine drug screen, then I know, and Mary, you can correct me if I'm wrong, but Fremont, I know, was using this quite a bit. And I think there was like gift cards that they could get, or like a money type reward that they could then use. I think there was like a spin wheel that they were able to spin, and that was their reward. And it's pretty effective. The research supports the use of contingency management, because when we can tie it to a tangible reward, it positively reinforces that behavior, that whatever they came in and whatever that outcome was, it reinforces whatever the behavior that they had done to get to that outcome. And so this is the high evidence base for stimulant use disorders. One of the best, what a lot of our studies, some of the best outcomes are for stimulant use disorder patients, that when they come in for a urine drug screen and it's negative, they're not using methamphetamine or cocaine or whatever stimulant. The highest evidence-based research that we have on it is for the stimulant use disorder, that when they receive this tangible reward, they feel really good about it. They have positive thinking about themselves, and their emotion changes, and then the resulting outcome of their behavior. And that, so we're focusing on that behavior aspect. And so an example of this for a patient that I've had, this was for a male that was 28 years old. He came in for cocaine use disorder. He was enrolled in an outpatient program and received vouchers for negative urine drug screens. So this was an intensive outpatient program specifically. And this outpatient program actually used vouchers. And these vouchers varied according to what the patient wanted. They had different choices that they could choose. They could choose like restaurant vouchers. One of them was like one of them was a movie theater. They were like a lot of fun activities to kind of reinforce behaviors, but the patient's got to choose whatever voucher according to what they like the most. And then once they were able, they were part of this program, and then as we geared towards moving them back to just outpatient treatment, then the primary care provider coordinated their medical monitoring and follow-ups. And then we actually continued to still provide those vouchers. They would still come. We ended up moving it to about monthly, and then every 3 months, and then every 6 months, that they would still come in for those urine drug screens, and then could still receive those vouchers. Dialectical behavior therapy. Again, this is another type of psychotherapy that there's a lot of evidence to support its use, and it can be used in many different conditions, particularly with our psychiatric conditions and with substance use disorders. When we think of personality disorders, this is the treatment option that is the most effective for a personality disorder individual. So if you see some of those traits, or you see that in their history with substance use disorder, this would be the preferred type of psychotherapy in order to create those positive outcomes and treat the substance use disorder. So a dialectical behavior therapy combines the mindfulness aspect, the emotion regulation, and then distress tolerance. So again, our goal of this therapy, we're not getting the patient to insight. We're not having them, we're not taking them through their whole life and understanding why they act this way, why their emotion is this, why this emotion creates this behavior. That is not the goal of this type of psychotherapy. That is a much more intensive psychotherapy, and not in any way are patients ready for that, especially with comorbid substance use disorder. So we're not trying to have the patient develop insight of any trauma that led to this personality disorder and led to these outcomes, and why we're using substances. No, that is too complex, and is not going to be the effective way of actually treating the substance use disorder. So here we're actually just combining mindfulness strategies. And so the goal of this is that when they have this emotional dysregulation from whatever happened in their life, and they have this big emotional response, and they become very distressed, our goal of it is to give them strategies to reduce that emotion on their own, and so they don't then react impulsively and react in kind of big ways because of the big emotions, and then that leads to more substance use. So here we're just giving them coping strategies like mindfulness, whether it's getting them to see this trigger and then reach out to a friend or go for a walk, whatever it is for that individual patient. We're getting them to feel the emotion and immediately go right to this strategy, so that we can change the distress that they feel. So again, we change the emotion, we change the thought, we change the emotion, we change the behavior. So an example of this would be for a patient that I had. She was a 30-year-old woman. She had opioid use disorder, and she actually had been diagnosed with borderline personality disorder. And the first thing that I usually check when I see these patients is I actually assess to see if the personality disorder is accurate. In her case, it was. So she was having frequent relapses, and it was triggered by interpersonal conflict. So this is the most common reason for these frequent relapses for a person with borderline personality disorder. So these interpersonal conflicts are constant, and it's with all of the individuals. So people with borderline personality disorder see all good or all bad. They can't see this individual as being potentially both. And so whatever conflict happens, this person is now, bad. Now they are very distressed. It creates a big emotion. They feel a lot of abandonment, and those feelings don't feel good. And so it results in that negative emotion, and they go right to using substances. And that essentially numbs out what they have to feel. So when we intervene, we're intervening on that pre-thought process. When they initially start to feel it, we give them these strategies to change their thought pattern. So when they get into that conflict, getting out of the situation, calling a friend, going for a walk, mindfulness, breathing exercises, where all of that comes into play and changing the outcomes for these patients. 12-step facilitation therapy, our 12-step program. I just want to mention it here. It can be very effective for certain patients, especially for alcohol use disorder here. It's not going to work for every patient. It does have some components that may not be helpful for some individuals, but even with like a religious aspect, it can still be helpful for individuals, even if religion or spirituality is not important to somebody. So it's working on these steps such as AA, and that's more of the focus on accountability, and it incorporates religion and spirituality. NA, the SMART programs, all of that. But the whole point of it is building this network, building this accountability and the social support. This is why I encourage all patients to use these type of treatments, even though if they might have any negative connotation or this preconceived notion of what it is, I encourage all patients to go to it, because it's actually incredibly helpful, because you get this social support, you get this accountability, especially having that support person, that person who calls in and frequently checks on them, who's been through the whole program and is able to come out successfully. And so they understand what the behaviors, and they understand what the kind of defenses are that person's doing, and can still bypass those walls and help that individual. So it works really well for the maintenance phase, because we have that supportive network and that accountability where we're meeting weekly, twice weekly, whatever it is that they're doing. And that encourages the relapse prevention. And an example that I had for a patient, this was for a male that was 50 years old. He had alcohol use disorder. And he initially came in and he didn't want to do anything that involves other people. I brought up AA, and he's like, no, that's not me. There's big groups there. I'm not religious. They talk a lot about spirituality, things like that. That's not for me, and it make me really uncomfortable. And so I was able to get him to go to one retreat. They were going on like a 24-hour retreat. And I was able to convince him just try that. And if he tried that and hated it, then we'd go on to step 2. And he came back, and he had entirely different feelings about treatment, about himself, about alcohol use disorder. We were still drinking just as much as we were before, but his feelings about himself and about treatment itself drastically changed. And so he was able to continue a participation. Initially, what wasn't really participating was just listening to everybody else. And by the end of it, by 3 months, he had been in remission for 3 months. He was leading some of the sessions. And so where he had this kind of preconceived notion that it was not going to work for him, ended up being the best treatment for him. And his sponsor was great, constantly checked in on him. He ended up becoming, by 3 months, he was really, really good friends with his sponsor, and they were meeting frequently to kind of hold him accountable and that having that supportive network. And then I just want to mention brief interventions. So these are things that all of you are doing in your practice already for substance use patients. And these are just very brief time limited techniques, and they're focusing on changing that person's behavior. I mean, that's ultimately always the outcome of all of these treatments, right? Whether indirectly or directly. That's ultimately the outcome that we're hoping for, and that behavior being the substance use disorder. And it's using counseling to motivate the person to reduce, in this case, such as their alcohol intake. This was a study that looked at it. And this was a 3-year study of heavy alcohol use in Finland that found that even brief interventions, I believe it was, I think they had like a 3-minute mark that where we just kind of briefly talk about it. Even that was effective in reducing consumption for some people when administered in general primary care practices. So it looked at 14 different studies, and it found that when patients received these brief interventions, there was a greater reduction in alcohol consumption compared to the control groups. And this was done by self-reported alcohol consumption at 1-year follow-up, also favored these brief interventions. So even these 3-minute interventions, whether using motivational interviewing, whether using CBT principles, whether using DBT principles or contingency management, whatever it is, they have such a positive outcome and reducing the relapse. And even at the 1-year follow-up, these brief interventions favored intervention compared to no intervention. And so I always like to put the cycle of change. Again, Notorium does a great job in showing these visuals. But the cycle of change that we're always considering: the pre-contemplation, contemplation, preparation, action, maintenance, and relapse. So the pre-contemplation and contemplation, when we think about motivational interviewing, we're kind of focusing on that aspect. So that when they, on follow-up visits, either with primary care or when they're referred to psychiatry or whatever, they've already hopefully at that preparation phase, and what's motivational interview can get them to that preparation phase. And so then we can start exploring, okay, let's start changing some of these thought processes, either through CBT, or we start rewarding the outcomes such as contingency management, or we give them the coping skills that they need, and such as with DBT. And then we can hopefully change that action, maintenance, and then relapse prevention. I always like to include a slide on documentation and billing when I talk about CBT or when I talk about psychotherapy, because all of you guys are probably doing some form of psychotherapy when you're seeing these patients, and these are things that can be reimbursed. So I included the most common psychiatric codes, which obviously these can be used outside of psychiatry, whether you use time-based or non-time based, if it's a higher complexity of care than the 213, 214, and 215. When you're using the EM codes, then you can add on those psychotherapy codes, either the 16 minutes or less than 30 minutes, above 30 minutes, things like that, or above 45 minutes. So if you're seeing a patient for 30 minutes, then and we're focusing on just the substance use, you more than meet criteria for meeting that 90833 code, which is the psychotherapy add-on code. If we're doing kind of just brief counseling codes, and we're using screening tools. So this is one that people don't commonly realize. If you're giving somebody a screening tool for substance use, that is billable. And I put down a couple of them. If we're just doing the screening tool, you can use the 99408 or 409. If we're using it with an EM code, you have to use the modifier of 25 to show that it's a significant, separate, identifiable service. And these are reimbursable. Some of the insurance companies require a different modifier. And so I always encourage providers to really focus on learning these codes, because the reimbursement pattern will kind of positively reinforce that. So almost like doing therapy with yourself, right? It'll positively reinforce continuing to use it in practice. And then it becomes the forefront in substance use disorder treatment and as the kind of research supports the use of even brief interventions, hopefully we can incorporate more of this into your guys' practice. And so it's not wasted time. You're not getting behind in your guys' daily schedule. And we're continuing to use the appropriate treatments for patients with substance use disorder. And then collaborative care intervention. This is one that I highly encourage across all providers within the person's life. I will always reach out to the primary care provider that referred the patient to me, especially if I'm in a system that hides the psychiatry notes or keeps them confidential, which they shouldn't be, right? The federal government kind of changed those rules, but some hospitals are still able to do it. So I will always make sure I send my notes over to the primary care office. And a lot of times I will try to make a phone call so that we can have that warm handoff between psychiatry and primary care, and making sure that we're all on the same page, whether it be medication assisted treatment, specifically with medication assisted treatment, so that when the patient comes back and sees you, we can have this positive view of how the patient's doing. So because a lot of times these patients have already kind of this negative view of medicine in general and the medical field. I mean, a lot of times they can come in the ER and there's a lot of stigma associated with it. And just little tiny statements can make such a drastic impact on these patients. Like, oh, you're back. Maybe if you stop drinking, then you wouldn't have, you wouldn't have pancreatitis again. Yeah, the patient knows that. But if we can just change those subtle statements, it can have such a drastic impact on their outcomes, their emotions, their thought process, and that pattern. And so if we can create kind of these warm handoffs and these positive way of understanding the medication assisted treatment, the therapies, this ultimately will have a positive impact on the patient's treatment and having that collaborative care integration. And I wanted to include this. I'm just about done. I want to make sure I give you guys time for questions, but virtual reality is actually a really cool up and coming possible treatment that they are looking at now in some of the research, but it's neat and I'm all for it. It's using these virtual reality environments, and what it's mainly focusing on is trying to create those cues in their environment that reinforce these relapse. So whether it's they see a particular building that makes them feel negative and that reinforces relapse, or whether it's a high stressful response, getting into an argument with their spouse or kids, and that makes them feel bad inside, and they're like, I don't like feeling bad, so I'm going to go ahead and use a substance because I'm going to numb it out. And so virtual reality is able to recreate these environments for these patients, even down to the people in their lives, their family can recreate exactly how these family members look and can even use their voice. So it's really, really awesome. And I'm all for it. You can tell I'm excited about it. But by taking patients through these exposures in a controlled environment of the virtual reality and not have access to the substance at hand, it can help patients, somebody else can be in the room and kind of help them pause the scenario and kind of say, okay, what are you thinking right now? Let's change that thinking pattern and let's try that scenario again. So really cool. I'm excited to see where this is going to go, and hopefully we can make this, something for all patients to use and not be limited to financial resources and things like that. So just the key takeaways, psychotherapy is essential alongside that medication-assisted treatment. A lot of you are probably already using it to not know that you can bill for it. So I just want to mention the billing codes and especially those screening tools, how we can get the reimbursement for that. And collaborative care is one thing I always encourage that increases outcomes for patients with substance use disorder. And then, of course, the future treatment option that is going to be awesome if the research continues to support it. And then I use I just want to acknowledge those slides that I use for Neuratorium for non-commercial education purposes. They're a great resource if you guys ever want to go through and look at some of those. They have great slides and great visuals if you guys ever do presentations on this. Any questions? How much time did I leave? Ooh, 9 minutes.
Hey, thanks, Stephanie. Yeah, any questions? Feel free to drop those in the chat, or you can speak up or raise your hand. We did get a comment from Mary. I think when you're talking about the contingency management, she said that we definitely use this reward system in probation. It works really well for kids.
Yes. And Mary, was that correct? Is it Fremont that has the spin wheel that when they have that negative urine drug scene, they get to go and spin the wheel for their reward? I believe it was Fremont.
Yes, they
Okay.
have. They bring in things like wacky tracks and things. And I'm telling you, even though they're little gifts, like their faces light up, they go up there, they're super excited.
Yeah.
So it's kind of a big deal. because anything positive is great. So
Yep.
yeah, that works well.
Any questions, comments from Stephanie this morning?
Hey, Stephanie, I got a quick question for you.
Sure.
Of kind of all the like modalities that you laid out for us today, like what one is, I would say like which ones do you use probably the most in your practice? And like if I'm gonna start using one of those, like what's the easiest one to sort of like grab onto and maybe just start trying with my patients?
So if we're already past that pre-contemplation phase, if we're already at the point where yeah, we need to change, we need to work on treatment, then CBT would be the best thing, the easiest, the thing that creates the most change quickly. And so again, we're just focusing on those negative thought patterns. So if the quickest way would be like, okay, what are you thinking when you feel that the bad feelings that lead to the relapse? What are you feeling in the moment? Well, I don't know. I feel like I have no friends. My family isn't supportive. I'm not great at my job. My relationship sucks. All of those will be this negative thought pattern. Take one at a time and say, okay, well, when that comes up that you think your relationship sucks, what do you think about? Well, we got into a fight. Okay. Well, what are the good things about your relationship? Well, my boyfriend says that I'm really supportive and I listen to him. Okay, this is great. Well, when you think that your relationship is not good, we got to then restructure it and say, nope, my relationship is good. These are the things I'm great at that I'm bringing into the relationship, and I got to focus on the positive aspects, and then that can create the positive emotion and results in the positive behavior. So that's the best way. And you don't have to do all of the negative things they tell you. You can just grab onto one in that moment and just focus on restructuring that one negative thought. And then the next visit, they come in and ask them, okay, tell me about experience that it happened and how were you able to restructure it?
Yeah, I think that's really helpful. Like, because a lot of times I think about cognitive behavioral therapy, like I need to send somebody to go and do that, right?
No.
But like,
Yeah.
if people don't know what it is, just like
Mm-hmm.
a simple exercise in it in the room in 5 or 10 minutes. And you're also saying that you can sort of bill for that. Is that what
Yeah,
I'm hearing?
absolutely. You can bill for it. And so if you're coming in for substance use disorder, I mean, you should absolutely be billing for these because the majority of the visit is going to be psychotherapy. And so you can, if you change the medication, you can add that EM code to the 99214, as long as you're kind of changing that, because that can be based on complexity, not based on time. And so then the time aspect can be focused on the psychotherapy. So you will get the reimbursement for both of those codes. And a lot of people think that, well, I don't have the time to get patients to develop that insight. And that's the most common misconception is we're not taking patients to insight. That is much more complex, and that is not the point of these therapies. We're not getting them insight. We're just changing their feelings and their thought pattern.
Yeah, that's super helpful. Thank you.
Yeah, absolutely.
We had a comment from Joyce. She says, elegant presentation on the various therapies. I have to say that in 2001, I presented a future idea using VR for therapy. My instructor told me that it was non-viable. That's kind of funny.
Well, Eric, I will disagree with your instructor because VR is awesome. I've been keeping up with a lot of the data, and it's truly, I mean, we have to get in times with the changing, with the change in the technology that we have, and VR therapy is going to be awesome. So, Joyce, I am on board with you. That's absolutely awesome that you recognized it in 2001.
That's great. Um, we've got a few minutes here. Rebecca Lewis says we use VR at our facility. That's great.
That's awesome. I love that. I love hearing about that.
If there's nothing else for today, I dropped a link in the chat to grab that evaluation survey and your certificate. And then just keep an eye out for some updates from me on our next series of echo trainings. Information on that should be coming out here pretty soon. So yeah, like I said, we'll be off in December, and then we'll hope to see everyone back in January and February. Thank you. And then Echo
Thank you,
team, if you
guys.
want to, Thank you. Hey, thank you, Stephanie. And the Echo
Yep.
team, if you guys want to jump over to that other link for a real quick team meeting, we can do that. Thanks.